session. So don't hesitate to interrupt and to ask any question. So I deliberately focus I prepare some couple of slides based on the questions Abby sent me. So we're gonna talk a little bit about hemodynamics in MCS. I think it's a basic topic, and it's really important to understand what's going on for patient under MCS. We are gonna look at the pump parameters and try to detail each of them and to try to give you some definition. I think it's again, it's very basic. Probably you are already familiar with this, but I think it's really important, and it could be easy questions for the exam. We're gonna talk a little bit about pre-op consideration, post-operative care, a little bit about right ventricular function in the setting of LVAD. We'll go over the Momentum 3 trial, and we talked very little bit about the cardiogenic shock definition and the classification, SCAI classification, and we will end with some consideration about LV distension under VA ECMO. So without further ado, I will start. So probably you already saw those picture. It comes from a paper published a couple of years ago now. And basically what you need to understand, this is PV loop curves modelized for patients who are under VA ECMO. And the idea is to understand what happens to the ventricle, to the LV, to the left ventricle, when you put someone on a VA ECMO. So it's a peripheral cannulation. It's a VA ECMO, so the blood comes from the right atrium and goes back in the usually the femoral artery. And it's really important to understand the effect of this. So as you see the curve, the blue one is a PV loop curve of a patient with heart failure. So he has a pretty wide curve, meaning that the volume of the LV is usually high, and the end diastolic pressure and systolic pressure is usually lower than it has to be. And when you put someone on ECMO and you progressively increase the output of the ECMO, you can see what are the consequences on the left ventricle. So the first consequence is, as you can see, the end systolic pressure increase. So you have an increase of your LV afterload. You have an increase, you see a shift, a right shift of the curves, meaning that the end diastolic pressure of the left ventricle will also increase. And you will have consequently an increase in left atrial pressure. So this is really important, and that's why we're going to talk about LV distension and the need of unloading a ventricle. The perfusion pressure increase as the systolic and the mean arterial pressure increase with perfusion. As you can see, the curve narrows with the increase of flow, meaning that the stroke volume decreases with the increases of flow. Usually, one of the other consequences of VA ECMO on the LV is you may have an increase of mitral regurgitation, and usually an aortic regurgitation is an absolute contraindication for VA ECMO for obvious reason. Those consequences, and especially the increase of end diastolic pressure, will lead to an increase of myocardial oxygen consumption, and at the end, an increase in blood stagnation. So, what those curves say it's in theory a peripheral VA ECMO. It's pretty bad for the left ventricle himself. And now it's interesting to understand what's gonna the effect when we reduce the peripheral resistance, arterial vascular resistance. When you do that, as modelized here on the gray curve and the orange curve, what the effect is, you're going to have a left side shift of the curves, meaning that you're going to decrease the end diastolic pressure and volume of the left ventricle. And you may have also a decrease of end systolic pressure, but at the end, you're going to increase your stroke volume, as you see the curve enlarge a little bit. So basically, those are benefit effects. So just acting on the vascular resistance and in the setting of VA ECMO, you can improve a little bit the hemodynamic at the left ventricle level. And that's why we usually aim for a mean blood pressure not very high, around 25 millimeter of mercury of mean arterial pressure in patient with a VA ECMO. And we try to avoid vasopressor. And as you know, intra-aortic balloon pump also decrease LV afterload, so and as a nitroprusside. So that's why we use those therapies, and we talked about it a little bit later. Another option to decrease the negative effect of VA ECMO is simply to increase the contractility using inotropes. And if you do so, even without reducing the vascular resistance, as you can see again on those curves, you start here with a VA ECMO at 4.5 liter, and if you just increase inotropy of the left ventricle, you're going to increase the end systolic pressure and systolic pressure, and decrease end diastolic pressure, and increase the stroke volume as well. So you may have some benefit effect as well. The detrimental effect of this strategy is you're going to increase your myocardial oxygen consumption, and there is no clear data or evidence to say if it's good or not in the setting of VFMO, and if you're going to delay the recovery. There is no data about it. But at least you can improve coronary oxygen delivery, and that's why most of patients on VA ECMO have still a certain amount of inotrope, again, to avoid LV distension. Here, they also modelized PV loop on the right ventricle in patient with VA ECMO, and basically there is no or almost none effect on the right side, which is not very surprising. Now, if we consider another type of support, so meaning the tandem heart. So in this setting, the blood is it comes from the left atrium through a transseptal cannula, and goes through the pump and is reinjected in the periphery, in the arterial femoral, in the femoral artery or whatever artery peripheral. And in this setting, it's a little bit different because you have an active unloading of the left ventricle. So you're going to have, because you suck the blood from the LA, and so basically you reduce the preload of the left ventricle, so you decrease the left atrial pressure, you're going to decrease the LV and diastolic pressure, and of course, consequently, you're going to decrease as well the stroke volume. As you can see, the curve narrow as the flow goes up. But the good thing is, in theory, you decrease the myocardial oxygen consumption. And in this setting, it's almost impossible to have LV distension. If you add some inotrope on a patient on tandem heart, what you're going to do is you're going to increase a little bit. You're going to increase you're going to shift the curve again toward the left, and you're going to increase the end systolic pressure and decrease the end diastolic pressure even more, and you're going to increase the stroke volume compared to no inotrope support. And in theory, you're going to have even more a positive effect in terms of LV dysfunction. So the third setting for mechanical support of the left ventricle is LVAD. So as you know, it's a more durable mechanical circulatory support, and you put a cannula through the apex and re-inject the blood in the ascending aorta. And what you're going to get, you're going to get the perfect LV unloading. And if you look at the curves here, the shape of the curves are triangular, are not rectangular as they used to be on that baseline, because the ejection through the aortic valve is almost flow. And as you increase the flow, you're gonna decrease the end diastolic pressure, and you're gonna decrease the end systolic pressure by unloading the left ventricle, and the pulsatility of the arterial line will slowly decrease with an slowly increase of mean arterial pressure. So the positive effect, you decrease the isovolumic phase, as you can see on the triangular shape of the PV loop, and you're going to decrease the myocardial oxygen consumption. You're going to decrease the left atrial pressure and the left and the end diastolic LV pressure as well. If you add inotrope in this setting, again, it's almost the same as the tandem heart. You're going to have, improve the LV discharge and increase the native aortic flow through the aortic valve. So one table that you should keep in mind, I think, it's the difference of the consequences on the LV between a VA ECMO and in the VAD and LVAD, for example, in terms of preload, afterload, stroke volume, and diastolic LV pressure and volume, systemic perfusion pressure, myocardial oxygen consumption, mitral regurgitation, aortic regurgitation. So again, in the setting of VA ECMO, you either you can decrease the preload if you have very, very good drainage and no flow through the transpulmonary or the pulmonary vessels, but you can you will have a huge increase of afterload. You're going to decrease the stroke volume, increase the end diastolic LV pressure, increase the systemic pressure, and increase the myocardial consumption, and increase the mitral regurgitation, and certainly exacerbate an aortic regurgitation. So I think this is one of the things you should keep in mind, and it's going to help you to understand and manage a patient under MCS. I don't know if one of you have any question regarding those aspects. If no, I will continue. So the next part is a little bit more dedicated to durable left ventricular assist device. So you are familiar with the HeartMate 3. This is the only commercially available LVAD right now, since the HVAD was withdrawn from the market because of an increase of stroke and a decrease of survival compared to the HeartMate 3. So I think the most important particularity of the HeartMate 3 is his hemocompatibility. And his hemocompatibility, as you know, is related to the increased gap between the rotor and the cage of the pump, actually. And it's almost 10 times larger than in previous pumps, meaning that the shear stress on the blood is much lower than previous pumps, and you also may have a decrease of von Willebrand factor activation. And this simple fact is probably the cause of all the observed phenomenon we're going to talk about in the momentum trial, with a reduction of bleeding, pump thrombosis, and embolic event. So one thing you may be aware of, so on this screen, on this slide, you have arterial waveform of a patient supported with a HeartMate 3. And the red, of course, is the arterial line. It's a radial arterial line. And as you can see, there is a little bit of pulsatility with the deep and with the kind of deep and up form. And it's important to understand what is this and why you observe that. One of the particular feature of the HeartMate 3 is it's called the artificial pulse mode. So basically, every 2 seconds, the speed of the rotor will decrease by 2,000, and for a fraction of a second, and then right after it's gonna increase for 4,000 RPM, and then go back to the baseline. The intent of that is not to reproduce a true pulsatility. It's more to improve the washout of the pump, and it's not synchronized to the native heart rhythm. So it's not clear if there is a real effect of this kind of pulsatility, but certainly the washout is the most important effect. And what you see, if you look at the schema here of the curve, you can see the 1 and the 2 are related to the native systole and diastole pulse in one sense, and the 3, the deep plateau, corresponds to the decrease of 2,000 RPM, and the 4, the peak, this little peak, correspond to the increase of the speed of 4,000, and then you go back to the baseline speed. So that's why you have this kind of waveform for a patient under HeartMate 3, and of course, the native pulsatility can vary according the patient condition and volume status and etc. and intrinsic contractility. But I think it's important to notice. So one element, it's very basic, but I think it's really important to understand the determinants of pump flow. So we are talking about the pump, we are not talking about the ventricle, but what are the determinants of the pump flow? So the first concept I'm going to talk about is the pressure head. I'm pretty sure most of you are already familiar with this concept, but I think it's really important. So the pump head pressure, or pressure head, we're gonna call it H, is a difference in pressure from the inflow to the outflow cannula. In other words, it's the gradient of pressure between the LV and the ascending aorta, and this is the absolute value of this gradient. And it's really important to understand that because the pump flow Q, the pump flow, is inversely proportionate to this gradient. So on here, on the right, on the left corner, you have what is called the HQ curve, meaning it's the relationship between this gradient here on the Y and the pump flow on the X. And every pump at every speed will have his own signature and his characteristics. And the centrifugal and the axial pumps will not have the same pattern of HQ curve. And those HQ curve tells interesting things about hemodynamics of the pump. On the red line here, you have the HQ curve of the HeartMate 3, and as you can see, the first part of the curve is almost flat, and then it's going to dip on the second part. So meaning that for low flow, you have a dip, you have almost a flat line, and as the flow goes up on the pump, you have a deep slope, more deeper slope. So it's a curved line. And so basically, what does it say? It's that for a small variation of the pressure head, of the gradient between the LV pressure and the aortic pressure, you have a large variation of the pump flow, meaning that this kind of pump, the centrifugal pump, are a little bit more sensitive to afterload than the axial pump. In green, you have the line for the HeartMate 2, which is an axial pump, and it's almost a line, a straight line. And for the same variation of flow, you have much higher variation of the pressure head. So that's really important to understand that. And the pressure head varies through the cardiac cycle. Here, it's the same information, but with a different representation. You have here on the brown curve is the LV pressure. So diastole and systole is going to increase. The red curve is the aortic pressure, the pressure in the ascending aorta. And the diastolic, as you know, is higher the aorta than the left ventricle, but they are pretty much the same in systole. And as we said, because the flow is inversely proportional to the gradient between those two curves. As you can see, in diastole, the gradient is higher than in systole, meaning that the flow through the pump is going to be higher in systole than in diastole, and that's why you have a certain pulsatility of the pump. And this is the same representation here. You have the pressure head in diastole is much higher. In this diagram here, you have the pressure head in diastole, the pressure head in systole, and then the flow is going to be higher in systole than in diastole. And here you have exactly the same that we said, and you can see the difference between the HeartMate 2. So those curves, you have the pressure head, you have the pump flow, and you have the curve at each RPM. So as you increase the RPM, the flow gonna increase. And one important thing is the shut-off pressure is the pressure at when the pressure gradient across the LVAD for a given set speed that leads to net zero flow. And this shut-off pressure is much lower in the HeartMate 3 than in the HeartMate 2. Because the HeartMate 3 is much more sensitive to afterload than the HeartMate 3. So going back to the determinants of pump flow, of course, the pump flow is related to the rotor speed. As you increase the speed of the rotor, you're going to increase the flow, almost not linearly, but almost. And this parameter is usually fixed. We set the pump speed, and again, the pressure head that varies through the cardiac cycle. And the third parameter is the blood viscosity, which has a minor effect, but still we need to enter the hematocrit because as we're going to see, the flow is not measured, it's calculated, and the blood viscosity enters in the calculation. So again, the pump outflow Q is directly proportional to rotor speed, and Q is inversely proportional to H. And you can modelize the device flow as the rotor speed divided by H. So when you have a patient on LVAD, you have the screen. I'm sure you have seen this type of screen. This is the screenshot of HeartMate 3 screen, and you have a couple of parameters you need to be familiar with. The first one is the pump speed, as we said. So usually the pump speed is fixed. We set the pump speed in the OR and we adjust it in the ICU or in a clinical setting under echocardiography guidance. usually it's related to the body surface area and also the left ventricle size. It's usually with a heart rate rate around 5,000, between 5,000 and 5,100. So again, there is a little bit of variation because of the artificial pulse mode, but doesn't appear on the screen. And you can have some automatic adjustment of the speed in certain circumstances, and we're going to talk about it a little bit after. But if you have a PI event, you have an automatically decrease to low speed limit to allow the left ventricle to fill again, and then the pump speed going to increase slowly afterwards. If you have a low voltage hazard alarm, again, you have a power saving mode, and then you're gonna have a decrease of the pump speed. And usually the low speed alarm is set by the clinician, and you have to know that below 3,000 rotation per minute, the flow gonna reverse through the pump. So this is a very minimum to set. So the pump power, so this is a pump. So you have different component of the power. You have the power of the system. You have the ground power, which is the power between the controller and the battery, and you have the power, the pump power itself that include the driveline power. It is the energy required to go from the controller to the pump itself. There is a bearing power and the rotor drive power. And that interestingly for the HeartMate-3, what is measured, it's a direct measure of the rotor drive power. So this is exactly the amount of energy that is required to make the rotor run. And it's a direct measure. This is the only direct measure we're gonna have with the device. And this measurement can change in response to shifting hemodynamics or pathophysiologic insults. That's why it's interesting, and that's why they use the power pump is used to calculate the pump power is used to calculate the flow, to derive the flow. It's measured over 15-second intervals, and they do the summary of those 15 intervals. And we talked about it later, why it is important. And another important parameter you're going to have is a pump flow. Again, it's not measured; it's an estimated flow based on the rotor drive power. So it's an algorithm put in the system. The pulsatility index. So I think it's one of the definition you need to know and to understand what it represents. The pulsatility index represents the relationship of the maximum to the minimum differential with the average power. So in other words, it's the power max mean, the power mean above the power average. You can also use the flow. So the maximum flow minus minimum flow above the flow average, you're going to have the same estimate. And the PI reflects the variability of the pump power, which is directly to the variability of the pump flow. So basically, it's a reflect of what's going on through the pump. And you're going to have a lot of information from that. So you have to understand that the arterial pulsatility is totally different of the pulsatility index. The arterial pulsatility, whether pulmonary or systemic, is the difference between the maximum aortic pressure and then the minimum aortic pressure. The pulsatility index, again, you can use either the power or the flow. It's a ratio between those two. So again, PI represents the magnitude of flow through of the flow pulse through the LVAD, and it's a reflect of the circulating blood and the native contractility. I think we had one question about that in our exam. So a fall in a PI should prompt evaluation of volume status and native LV function. So we're going to talk about it a little bit later. So now another important idea is a PI event. So a PI event, what is this? So first, usually we misunderstand and we associate PI event to suction event. It's not exactly the same. A suction event can trigger a PI event, but it's not the same. A PI event is something that is detected by the pump, and it's triggered if there is a greater than 45% difference noted between the per second PI and the average PI. And that's why it's important when we say it's measured every 15 seconds, because that's measurement allows a pump to detect PI event. This difference can be driven by either the power max or the power mean. So if you have a sudden change in the flow or in the power in the pump, then the pump gonna detect it, and it's called a PI event. And then in response to a PI event, the pump speed will automatically drop to its low speed limit and then re-advance to the set speed in 50 RPM increment for the hertmetry. That's the progressive return. And I think it's really important to know what triggers a PI event. So you can have, usually it's a reflection of sudden changes in LV preload or afterload. So you can have a sudden changes in patient volume status, in power or pump speed. You can have arrhythmias, ventricular suction, coughing, sneezing, or intra-aortic balloon pump. All of those elements can trigger a PI event. So now you have to integrate. When you look at the pump, of course, you look at the patient, but when you look at the pump, you need to integrate those parameters to sometimes try to understand what's going on. So here it's kind of a summary of different clinical setting and the parameters. So on the left side, you have the pulsatility index. So the PI, it could be high, normal, or low. Usually what matters is the basal value, and the changes from this value are even more important than the absolute value of a PI. So usually a normal PI is considered between 3 and 8 or 3 and 6. And if it increase or decrease, something is happening. And on the X, you have the flow. So on the right side, you have high flow. On the left side, you have low flow. So you can have a mix of situation. You can have a high PI with a low flow. You can have a stable a PI with a high flow, or a low PI with a high flow. And every situation means something. So if we go here from the right up, meaning that you have a high PI on your screen, but a low flow again. So it can be if the patient has hypertension, hypovolemia, the speed set is too low or even sometimes too high. You can have arrhythmias, intra-aortic balloon pump. If you have a stable PI and a low flow, maybe you have a too low speed, or and you need to increase the speed. We're going to talk about it a little bit later. And if you have low PI and the low flow, this is bad. So I mean, there is no blood flow through the pump, so you can have a tamponade or flow occlusion. And the normal setting is you have a stable PI and a normal flow. And if you have normal flow with low PI, maybe you have a offloaded LV, so you need bolus fluid or something like that. If you have very high flow and stable PI, it's because of your patient has a big BSA, and in setting of aortic insufficiency, you have a kind of a loop. and you have very high flow in the pump, but a low PI on your screen. So if you look at some different clinical scenario here, you can either go by the clinical scenario, what you're going to have if you have, what's going to be your flow estimate, your power, your PI, and do you have PI event in clinical setting? So for example, one of the most common scenario is severe hypovolemia in the ICU. Then you're going to have a decrease of flow, decrease of power, increase of PI in the setting of the HeartMate 3, and you're going to have a PI event. Why you're going to have an increase of PI is not really, it doesn't make really sense, but in fact, it's because you're going to have a huge variation of the blood flow through the pump, because you have an empty left ventricle, and you still have a kind of some blood pressure in the aortic valve, so your pressure head is still increased, and you're going to have a lot of variation. But it's not the same with the HeartMate 2, for example. But with the HeartMate 3, it's kind of counterintuitive, but you're going to have an increase in PI. In the setting of hypertension, makes sense. You have you increase your pressure head, so the blood, the flow through the pump going to decrease, so you have a low flow state. Your power going to decrease because you have a low flow, and your PI increase, and you can have a PI event as well. In the setting of tamponade, you have low flow, low power, increased PI, and PI event. Severe right ventricular failure, low flow, arrhythmias, low flow. So again, you need to have an idea of each clinical situation. It's a little bit easier with the HeartMate 2. It's a little bit more intuitive. So if you have, let's say, a low flow and a low PI, usually you think about hypovolemia, tamponade, right heart failure, arrhythmia, or graft obstruction. If you have a low flow with a high PI, it's more likely hypertension, low pump speed, or inflow or outflow graft obstruction. If you have high flow and the low PI, it's more hypotension or high pump speed, and a high power, high flow, and a high PI, it's a normal, or it's because of the recovery of the intrinsic LV function. And we're going through algorithm to try to facilitate you the thinking in this about these parameters. Do you have any questions so far? Okay. So here I put some slides just about some. It's a general consideration, but I think you really need to be familiar with. You really need to know what are the red flags for advanced heart failure. You may have a question about that, saying, okay, this patient has this condition, is that, or just ask you what are the red flags for advanced failure, or just present you a patient with those characteristics. So if you have a patient with repeated hospitalization, need of intravenous inotropic support, of course, NYHA class 3 or 4, reduced VO2, and etc. Those tables are derived from the AHA 2022 guidelines for heart failure, and I really encourage you to know those very, very well, because they are well done, and they are pretty exhaustive, and this is really what you need to know. So I won't go through all of those tables. You're going to have it. Again, indication for durable MCS, I think it's really important. Nothing fancy here, but this is something you have to keep in mind. What is the level of recommendation for what is the level 1? It's if you have basically a patient with an max 3. 2A, it's if you have a patient with a NYHA of class 4 despite GDMT, and 2A is patient with cardiogenic shock and who needs temporary MCS. So you need to know all of those recommendations. And the contraindication, there are absolute if there is an irreversible condition of the patient and severe psychosocial limitation or medical non-adherence. There are many relative contraindication, and they can vary from center to center. So, but you just need to have an idea. I really encourage you to know very well the Entramax profiles, because what you can have, it's a description of a patient, and they can ask you, okay, what is the Entramax profile of this patient? It's just learn. It's not very difficult, but sometimes the differences are not that obvious between, especially the 5, 6, and 7. So I really encourage you to know this definition very well. I won't spend too much time on this. I will say a couple of words about pre-operative optimization. I think it's really important, and you need to have clear objectives before the OR for a patient who might need an durable MCS. So the first, you need to think about the right ventricle, and you need to optimize the right ventricle. That's why you need to lower the pulmonary vascular resistance. You need to manage appropriately the volume status. If you need to diuretics, CRT, you need to have numbers of hemodynamics to guide the diuretics. You need to improve his nutritional status if it's feasible, to reduce hepatic congestion, to treat and prevent any infection, to improve coagulation. Some centers that give vitamin K before, prevent acute kidney injury, prevent vasoplegic syndrome, and improve O2 transport, oxygen transport. So that basically those are the main goals you want to achieve before an MCS, durable MCS. So if you need some targets, it's not. I mean, there is no no clear guidelines, but this comes from a paper and the Canadian Journal about it, and I think it's pretty decent reference to use or to cite. So you have again, you have to aim for a good hemoglobin, normal hepatic function, and etc. So you will have all of these. Most important is the hemodynamic parameters with low CVP. It's really important. Just a couple of words. I won't go over the detail for MCS for the surgical technique. Not sure if it's part of your objectives, but I think the intraoperative echo assessment is something you need to be aware of. So before CBP, you need to assess, as usual, the valves, because if you have a severe or moderate AI, that might change your plan. You need to rule out a PFO. You need to look at the right ventricular function if there is an LV thrombus. Once you put the VAD in and you transition from CBP to the LVAD, you need to to make sure that there is no air, to look at the volume status, the contractility of the right ventricle, to assess the valve again, the inflow cannula position, and look at the RV function. That's going to drive with the hemodynamic parameters your strategy for coming out of bypass, and if you need something more. So it's really important. Now you saw that change in the blood, in the mean pressure, or in the pressure head may affect your pump flow. So that's really important, that in the perioperative period, you want to have the most stable mean arterial pressure as possible. Because if you have abrupt sudden changes in your mean arterial pressure, you may have abrupt changes in your flow. So meaning if you have a patient with a MAP at 80 and suddenly drops his MAP at 55, what you're going to have? You're going to have a complete unloading of the left ventricle because your flow going to increase too much through the pump, and then you're going to have a shift of your septal shift toward the left, and then your right ventricle gonna fail. So it's really important to understand that concept and to try to keep an LV afterload or pump afterload as much as steady as possible. So you can have some idea of hemodynamic targets you may want in the perioperative setting. So usually we aim for a CVP around 10, 12. A mean arterial pressure for the first couple of hours around 80. 90 is a little bit high, but 80, 90. The VAD flow indexed, we aim for 2 or 2.5. We usually use inotropic support for the right ventricle and the slow wean of inotropes or pressure. And we're going to talk about it, but if you have a CVP above 20, you need to do something, and especially if it's associated with a decreased renal function or diuresis, you need to act rapidly. So now it comes some clinical scenarios, and it's pretty classic, but I think it's important. So you're in the ICU. You have a patient who just had a VAD, let's say, and his MAP now is he's hypotensive. So his MAP is below 60 millimeter of mercury. So the next question you have to think of is, what is pump flow, or what is his arterial pulsatility? If it's high, first, it's okay. There is no kind of emergency. So you have a high flow. So the next question is, okay, why you have a high flow? And we see you can have a high flow for many reasons, and probably because afterload is kind of low and you have vasodilation. So now you have to think why you have vasodilation. It could be, is it related to a sepsis or not? So you can just, if the patient has fever, then it's pretty easy, and you look at for sepsis and you do the culture and all the blood work, etc. And if you have no fever and no sign of SIRS, then it's probably because of some or vasoplasia, something. So you need to hold vasopressure and eventually initiate vasopressure. So this is pretty easy. Now, if you have a low pump flow, it's because of either hypovolemia, because it's a cardiac problem, or it's because there is an obstruction somewhere. So the next question is, what is a CVP? And if the central venous pressure is low with a decrease of PI, and you have a PI events on the screen log, you need to think, okay, is my patient bleeding? So look like hemoglobin or just chest tube, and if it's low, then you look at the bleeding, you try to fix the bleeding, or you reverse the anticoagulation, you transfuse, and you manage the bleeding. If the hematocrit is adequate, maybe and there is no bleeding, you just need to bolus the patient. If the CVP is high, then you need to get a TTE or an echocardiography to figure out what's going on, and also a PA catheter might be useful, because one of the first reason obviously is a right ventricular failure, and then you need to optimize a RV preload, afterload, inotropy, ventilation, hemostasis. We're going to go through this. And you can rule out tamponade, a pulmonary embolism, a pneumothorax, or simply you can have an inadequate LV unloading because the pump speed is not enough, or you can have a pump malposition. So this is a basic and kind of the way to think and to approach a systematic approach for problems. So the first thing is MAP, pump flow, CVP, echo, and then you can figure out what's going on. This is another similar algorithm, but presented differently. So you have a low pump power. So we are on the scenario where you have a hypotension associated with the low pump output, and then you need other parameters as CVP and echo to dissociate what is the problem, to answer what is the problem. This is exactly the same, but I think the algorithm is a little bit more clear. So you're gonna have it. So that leads us to the right ventricular function under LVAD. So I think it's really an important topic. So you need to know what are the signs of right ventricular failure in a patient with LVAD. So it's if you have an increasing vasopressor or inotropic requirements or hemodynamic instability, you need to think about it. If you have elevated or rising CVP, a decreased urine output, and a low mixed venous oxygen saturation. This is classic feature of the right ventricular failure. There is a standardized criteria for the diagnosis of RV function. There is also the Intermax definition, but it's basically it could be an inability to wean from cardiopulmonary bypass. This is pretty obvious in the OR. Or if you have a low MAP, a high CVP, SVO2 below 55, LV flow rate, low pump flow, or a significant inotropic dependence. But I think this is a pretty accepted definition for right ventricular failure. And again, echocardiography is the main tool to diagnose this condition. What are the causes or the mechanisms of right ventricular failure after an LVAD? So first, there is a preload consideration, and it's exactly the same when you think about the treatment. You need to think about the preload. So is there volume overload? If you transfuse a lot, or if you give a lot of volume to your patient, is it because you set the speed too high? Then you increase your venous return, and most importantly, you're going to have a septal shift towards the left, and you're going to decrease the intrinsic contractility of the right ventricle. Or maybe because you have a huge tricuspid regurgitation and you have no forward flow towards the PA. Then you need to think about the contractility. Is it because your right ventricular function is poor before LVAD implantation, and you want to avoid to be in this situation? Is it because you have an ischemia, inflammation, ventricular arrhythmias? You need to think about afterloads. Is this because your ventilation is bad and you have an increase of your PVR, or because your LV is not well unloaded? So you need to have in mind a couple of predictors of right ventricular failure. There is no one that's going to predict well RV failure. So I don't think you're going to have a question about that, because there is too many predictors from too many studies with too much heterogeneities. But still, some are pretty strong, like age, female, need for mechanical ventilation before LVAD, need of dialysis, high INR, high NT-proBNP, high CVP, and some other parameters. I think you really need to know those parameters. So RV score, no one of those is really good. The most common use is the U-Michigan score, but the correlation is not great. But as you can see, there is hepatic renal parameters and use of vasopressure. This is one of the classical ones. But I think those hemodynamic parameters are more important, and we use them a lot in clinic. So you need to be familiar with. The first one is the ratio between the right atrial pressure and the pulmonary capillary wedge pressure. And if it's above 0.63, it's bad. If you have a right atrial pressure above 15, it's also bad. If you have a RV, LV, and diastolic diameter ratio above 0.72, it's also bad. If you have the pulmonary arterial pulsatility index, and you need to know the formula, which is the systolic pulmonary pressure minus the diastolic pulmonary pressure above the right atrial pressure, and if it's below 2, it's not great. And finally, the right ventricular stroke work index, which is the stroke volume index by the mean arterial pressure and a constant. If it's low, lower than 11 gram per meter, or another formula is less than 300, it's bad as well. So again, the principle to prevent and to treat the ventricular RV failure after LVAD is you want to improve your ventilation or optimize your ventilation, avoid acidosis, optimize your PVR and the LA pressure. You need to act on the native contractility with inotropes to make sure the coronary perfusion is adequate, to avoid arrhythmias and to avoid cardiac dilution. And you need to have a patient with euvolemia as much as possible to protect the renal function and diuresis the patient if it's possible. So again, afterload, you can use nitric oxide or Flolin. You can have, you need to optimize ventilator, warm the patient again, and minimize transfusion. So this is pretty classic, and it's pretty the same for RV dysfunction. You might be familiar with those type of, when the medical treatment fails, we have tools we can use. We can have the VA ECMO in this setting is not really used, so we can use either a PA or an array cannulation centrally using either a tandem RVAD or a CentriMag. Centrally, we can use a RP Impella or Protect Duo cannula through the jugular vein. So there are many options we can use. Just you can cite them. Here it's a pretty busy table, but I put all the formula that you may want to know, and you maybe will be asked. So you're gonna have it. This is formulas about oxygen consumption, hemodynamics. So I won't go through, but you're gonna have it in the slides. So now, Momentum 3 trial. Abil, just let me know if we need to increase the speed or if we still have time.
Yeah, no, it's completely up to you, Pierre. Yeah.
Oh, I have time. So we can speak about this. So I guess you are all familiar with the Momentum 3 trial. There is 4 publications. The last one is 2022, and it's a 5 years update. I put here a couple of important findings or important things you may want to know. This slide is derived from the 3 first papers. Basically, the design, it's a randomized controlled trial, non-inferiority. The population is 1,028 patients eligible for bridge transplant and destination therapy. I think you need to know the inclusion and exclusion criteria. I will go right here. I put them here because you may have a question with the patient and say, okay, is this patient eligible to Momentum, or I don't know, but it's a possibility, and you have to be aware that only 45% of LVAD candidates are eligible to the Momentum trial. So it's not a good perfect reflect of the reality. I put here some, so you need to have a good idea of the patient's characteristics, like in terms of age, sex, intermax profile, and the intended goal of support. I think it's important. And here is a summary table of the final report. So it's pretty old now, but I think you may have. It's possible you get a question, more likely about the 2022 papers, but still. So here you have the main features. So the primary endpoint, you need to know what is this. It's a composite endpoint, and you need to know a rough estimate of the primary endpoint, the rate of the most important adverse event as stroke, bleeding, the death within 2 years, pump thrombosis rate, pump replacement, and the survival at 1 and 2 years. And you have here the table updated for the 5 year outcomes. So when you need to know it, the primary endpoint at 5 years, those primary endpoints: survival to transplant, recovery, LVAD support free of disabling stroke, or pump replacement at 5 years. It's 65% in the HeartMate-3 group and 47 in the HeartMate-2, which is significant. And you have a couple of other adverse event or complication. And also, I think it's interesting for you because you're gonna have a rough idea of what are the rates of adverse event in this population. And the 5 years survival is 58% in the HeartMate-3 group and 39 in the HeartMate-2, which is significant, and which was not in the previous report. So I think this is probably the most important results here. So if we go back to the question Abby sent me, so Abby, how do you want to do this? You want to answer it and we can discuss, or how do you want to do it?
Yeah, so I think so everyone, those of you, I guess, who are on the line, if you did the exam, these are the questions that actually ended up on the exam. So maybe we can, and everyone, Pierre actually has the answers to these questions.
Okay.
So they've been distributed to the actual answers that they were looking for. But maybe if people had questions that are specific to, or if you had, explanations as to why the answers were what they were, that would be helpful. Yeah.
Okay. So if we go, so it's a 65-year-old man who underwent HeartMate-3 implantation 6 hours prior. You are called because his cardiac index is 1.5, which is low, of course. His CVO2 is 42, which is low. He's intubated, sedated on milrinone, and norepinephrine, pretty high dose. How you would approach each scenario? So his CVP is 5, PA pressure are pretty low. The MAP is okay, 80, no systemic arterial pulsatility in between HeartMate-3 pulse, and PI is low, RPM is 5100. So the way I would analyze that is, so the first question, the MAP is okay. Here we do not have the pump flow, but we assume it's fine. No systemic arterial pulsatility, and PI is low, meaning that there is it's either the contractility or either the volume. There is something related to the volume. Now there is no volume in the LV. Is it because the RV is not functioning, but the CVP is low? And the pulmonary arterial pressure is low as well. So if you increase inotropes, I don't think the need here. I think it's pretty obvious that the clinical scenario is because you have hypovolemia. So it's either the patient is bleeding or it just needs some volume. If you reduce afterload, I think you may increase, you make things worse because you're gonna increase the pump flow, which is not good, because if you have an empty LV, it's not good. And insert an LVAD, there is no right heart failure here. But I think it's pretty clear, and I agree with the answer. Any questions? Okay. His CVP is 14, which is a little bit higher, which is on the higher side. He has high PA pressure. The MAP is kind of too high. You have a good pulsatility pressure, good PI, and RPM is fine. So here, if you give some volume with a patient with a CVP already 14, is not going to do well. If you increase inotropes, I don't think I don't think why, because you have already a map and a good pulsatility and etc. And because of the PAP is pretty high, you have a PAPI, which the PAPI pretty high. So I don't think there is a RV failure, whereas the CVP is a little bit borderline. So I agree with the answer again, reduce norepinephrine dose. So now the third scenario, his CVP is a little bit still high, PA pressure a little bit on the lower side. The map is okay, but there is no systemic arterial pulsatility. We don't know the pump flow, but the PI is low, so the feeling of the LV is not great. So I think at this point you cannot tell what is going on, because you have a map is okay, or even a little bit low. Let's say it's a little bit low, and the CVP is a little bit high. So you need another you need other information to understand what is going on and to dissociate eventually a tamponade or RV failure. And so again, I agree with this answer. And so this part, you are called because this cardiac index is 1.5, CVO2 is 42%. So now you've done the TE and you have right ventricular failure. So I think we went through this 6 treatment options that could be considered to treat this problem. I think if you think about preload, contractility, afterload, it comes pretty easily. So you put optimize heart rate. So this would be contractility, correct acidosis, this is for afterload, correct calcium, this is for inotropy. This minimize propofol. Not sure that one. Why? Is there anyone who can comment on minimize propofol? No. Abby, no idea.
Yeah, these were the, I guess I actually did not realize that this wasn't a question supplied by you. This was by Chris White.
Okay.
Yeah.
I'm not sure why. Maybe there's something I don't know, but in my mind, propofol is a kind of vasodilator for pulmonary artery. So correct hypercarbia and hypoxemia for sure. Decrease PVR, of course. Increase inotropic support, yep. And finally, an RVAD. Agree. What we could add?
Hey, this is Jessica. I wonder if they're talking about like propofol infusion syndrome with right heart failure. That's just a possibility, but
okay. I don't know. Actually, maybe, I don't know. I have no clue about this. I think it's the first time I hear about this. But for sure, one other thing you can do is to decrease. You decrease the pulmonary the PEEP, the pulmonary expiratory pressure. I agree it's important to reduce atelectatic lung, but clearly the PEEP is an issue with in the setting of right ventricular failure. And if you can extubate the patient, of course, not with those parameters, but it's a good thing because you're going to decrease the right ventricular afterload. What is the estimated 5-year survival of a patient who received an HeartMate 3 VAD in the Mumbaton trial? So we saw that. How does this compare to the 5 years survival following heart transplant? Answer, yeah. So at 1 year is pretty the same, but after 5 years, transplant is better. So if you still have some energy, we can move on with just a couple of slides about cardiogenic shock. I think you need to know the definition of cardiogenic shock. It's pretty straightforward. There are many definitions in many studies, but the definition from the AHA guidelines is a consensus. So you need to know that definition, and I think you need to know how to calculate cardiac power output, because it's kind of a new parameters to assess hemodynamic of patients. And also the parameters related to the right ventricular function, as we already saw previously in the setting of VAD. I think the SCAI definition and classification is important. I'm not sure they will ask you to fulfill a table like that, but you need to know the classification to be able to classify a patient with some of the characteristics. So if you have hypoperfusion, if you have what is the definition of hypoperfusion, what is the definition of hypotension, if you have lactate normal, if you have lactate above 5, if you have cardiac arrest, etc. So you really need to, I won't go through all over this, but I think it's really important. I won't spend too much time on this. I'm pretty sure you all know all of these devices and what are the characteristics and the pros and cons. So you need to know all of that. Again, you're gonna have that in the slides. And we're gonna finish with those 2 slides about left ventricular overload distension. So the first thing you need to know that there is no clear definition or consensus, and you're gonna have only indirect signs. But I think it's really important to understand to know those signs. The first one and the pretty obvious one is a chest X-ray. You're gonna have pulmonary congestion or redistribution or edema on the X-ray. On the echo, you are gonna have indirect signs of LV distension. You can have, so first the aortic valve gonna be closed all time, so you will not have any pulsatility or very low narrow pulsatility on the arterial line. We have sign of LV distension with an increase. If you have an increase of the left ventricular and diastolic diameter, it could be related to LV distension. If you have a smoke-like effect, I don't know if all of you have seen that, but you can see like really some micro bubbles in the left ventricle or in the left atrial, and it's usually a sign of LV distension. And if the VTI in the LV outflow tract is very low, also it could be a sign of LV distension under VA ECMO. And finally, another indirect sign, if you have a high pulmonary capillary wedge pressure, if you have a Swan-Ganz catheter on your VA ECMO patient. And on that table, pretty busy, but you will have all the strategies to unload your left ventricle in the setting of a VA ECMO. So you have non-catheter based. So we already talked about this at the beginning of the course of the session. If you reduce the afterload and if you reduce the ECMO-related flow, that might help to decrease if you use vasodilators or moderate inotropes. And if you increase the PEEP, it's all of those measures or non-invasive actions that might help to decrease LV distension. And finally, you have catheter-based device, so you can unload the LV surgically through the right superior pulmonary vein, through the pulmonary artery, either directly or through with a percutaneous cannula. Again, a suction device in the pulmonary artery. You can use transatrial catheter if you do transseptal approach with a protect your cannula, you can vent directly your LA. You can use the apex of the left ventricle. You can use transaortic catheter or transaortic suction device. It's kind of an impella axial pump, or the intra-aortic balloon pump. So I think it's a pretty exhaustive table for all the strategies to unload the LV ventricle. And I think that answers the final question related to VA ECMO and LV distension.
One thing, Pierre, for this question, if I can just ask, because it was a very common response that people gave as an additional option. And I'm just curious if this is something that you would consider as an acceptable answer, is converting it from femoral VA ECMO to central.
No, I mean, I don't think I would accept that answer, because there is not enough data to support that. It's an assumption, but it would be the same with the axillary approach. So some people say, okay, if you put axillary cannulation instead of femoral, you will decrease the LV distension. But to be honest, I've looked at the literature and there is no good evidence to support that.
Okay, all right, thank you.
The way to think about it, you can have medical treatment, you can have active venting, passive venting, and yeah, you can describe all of that. Okay, and with that, I'll leave you with that. I'm sure you're aware, but I put here a couple of I think high yield studies of the momentum. We talked about it. There is an ECMO CS trial that was published recently. I think it's interesting. The REMI trial is pretty old, but I think it's also interesting. The SKY definition and the Inception trial for ECPR and ECMO, and of course the guidelines for heart failure management. So I don't know if it answers the question.